Hello friends, welcome to this session of COVID-19 and expected questions in the upcoming exams of FMG, INICT and NEET PG. And I'm delighted to have wonderful friends and esteemed faculty members, Dr. Salman, microbiology faculty, Dr. Saurabh Bhatia, pharmacology faculty, Dr. Anuradha Dhawan, ophthalmology faculty, and myself, Dr. Rajiv Dhawan, ENT faculty. So what's the plan for this particular video? That we'll be focusing on what are the expected multiple choice question in these subjects. And all the respected faculty members would try to tell you the high yield points relevant to that particular question. So first we start with microbiology, and I'll request Dr. Salman to start his set of questions. Thank you.
Hello, doctors. Myself, Dr. Salman, and I'm the faculty of microbiology at MIST. So as you know, we are going to do some MCQs related to the topics like COVID and mucormycosis in this session. Okay, and these are going to be very helpful for the upcoming exams like INICT, NEET PG, as well as FMG. Okay, so we'll just jump to certain basics first, and then we will start our MCQs. So as you all know, the coronaviruses, there is some kind of hierarchy and classification for that. But out of this, I would definitely ask you guys to remember the genus to which it belongs to, and it would be beta coronaviruses. Now, next thing, I'm sure you have looked at the structure so many times during this pandemic, but let's just throw some light and know what are the important things from this. So when you look at the structure of coronaviruses, please make sure you know there are certain proteins called as S, M, E, and N. You can remember them in a sequence like semen. And at the bottom corner, you can see the electron microscopic picture of that. Now, let's solve one MCQ here. What is the storage temperature of viral transport media if the sample needs to be stored for more than 3 days before the testing is done? That means if somebody has come to collect your sample for the RT-PCR, you know the samples are nothing but the oropharyngeal and the nasopharyngeal swabs. So at what temperature you're supposed to store them if you want to do the testing after 3 days? The correct answer to this, dear friends, it would be minus 80 degrees. Okay, now let's have a look at this. The transport media, I'm sure you have seen this. Okay, it's called as VTM or viral transport media. Now, if the testing is going to be done within the 3 days, the temperature is the regular temperature, that is 2 to 8 degrees. And if you want to do the testing much later, the temperatures are mentioned below, which is minus 80 or minus 70. Okay. Now, next thing, the direct testing for COVID is to detect some part of the organism itself. And that is nothing but the RNA of the virus is detected by different types of, NATs, nucleic acid amplification techniques. You know about the RT-PCR, CBNAT, and the TrueNAT. CBNAT is cartridge based, as you see the image, and TrueNAT is the one which is chip based. Okay. Now, guys, next thing what you should know here is the gold standard of testing is anytime real-time RT-PCR. Okay. There are certain genes, what we have just looked at within the structure that can be detected here. Okay. That are mentioned in the slide. You can have a look at these. CT value, you should know what is the concept behind this. CT value is inversely proportional to the viral load. That means less the CT value, the more the viral load. In simple words, they are saying that in less number of cycles that we perform for PCR, you can detect the virus, and that's not a good thing, right? There is a lot of virus. That's why we are able to detect the virus in very early cycles. All right. Next, another MCQ for you. A 45-year-old man has a fever of 104 degrees Fahrenheit since 2 days with cough, headache, lethargy, and muscle pain. He is a diabetic patient and his blood glucose levels are controlled with metformin. He was waiting for an appointment to get vaccinated against COVID-19, and these symptoms began in him. Okay. CBNAT was performed for RDRP, RNA-dependent RNA polymerase of SARS-CoV-2, and the test turned out to be negative. So now what should you tell the patient? What should you inform the patient? The patient is negative for COVID-19. The patient is positive for COVID-19. Do the e-gene screening test or go for the PCR. The correct answer for this would be the option D. That means you have to do the RT-PCR as it's the gold standard test that should be done. Okay. Now, this is the idea here, guys. So when you do the CB-NAT versus TrueNAT, you know, there is a difference of genes that you can detect here. In the RT-PCR, what we said, you can detect S, E, M, ORF, etc. Here you can only detect the E gene and the RDRP. So first step is to detect the E gene. So it's called as E gene screening test. If the test comes out to be negative, it's considered as true negative. If the test comes out to be positive, don't say the person has COVID right away. Do the confirmatory test called as RDRP confirmatory test. Okay. If this test turns out to be positive, consider the patient as COVID positive. If the test is negative, you have to confirm by RT-PCR. Have a look at the question. What did I tell you here? The person had RDRP test and that turned out to be negative. If the RDRP test is negative, doctors, what did we learn here? You have to confirm by RT-PCR. Okay. Next, keep an eye on this antigen testing. I'm sure you all know the concept behind this. I'm not going to go behind this. Okay. So these tests are based on a concept known as immunochromatographic tests. You know, these yield the results pretty quick. A very important question you can expect, dear friends. The culture of COVID, if you do, the SARS coronavirus, it should be only done in the BSL-3 level labs, whereas all the other tests, they can be done in the BSL-2 level labs. Okay. Next, which of the following vaccines is an inactivated whole virion vaccine? Okay. So guys, you know, there are different concepts of vaccines that are here in the market right now. So you see all the popular names that we all know about. Okay. The correct answer for this, as most of you might have answered, it is Covaxin. Okay. Now, let's have a look at this. The Covaxin is an inactivated whole virion vaccine. It means the entire virus is taken and it's in an inactivated form. You know, it's developed by Bharat Biotech and ICMR, and the temperature for storage is 2 to 8 degrees, just like the VTM, viral transport media. If you're doing the sample within 3 days, you use the same temperature, 2 to 8. So make sure you know this number. Okay. Next vaccine is Covishield. Now, Covishield vaccine is a little different. You're not taking the entire virus in this, but only a part of the virus. Now, what exactly are we doing in this? Okay, you're going to use another virus, okay, called as adenovirus, chimpanzee adenovirus. That's what is the name ChAdOx1. And that virus is going to carry the spike proteins for you. You know, the spike protein, S protein, is the main thing that helps the coronavirus to enter our cells. Okay, so this guy, what it is going to do, it's going to carry the S protein, and now your body will start making antibodies towards the S protein, and then you will be protected from this infection. And pretty much just like that, you have the Sputnik vaccine, you know, the one from the Russia, developed by the Gamaleya Institute. So that is also based on the pretty much same type of a concept. The third type of concept is the nucleic acid vaccines. That means you have a mRNA that you have trained to make some kind of specific protein for you. So this time, I'm interested in making S protein. You all know when you make mRNA from DNA, it is called as transcription. And then from the mRNA, when you make proteins, it's called as translation. So what you're doing is you're taking one type of a mRNA, and that is going to make S proteins for you. Okay. The vaccines based on this are Pfizer and Moderna. Okay. Now let's have a look at this question. Very important. A test called as 1,3-beta-D-glucan assay. It's used for all except. Now, generally speaking, this test, you know, it's done for invasive infections. Okay. And this beta-D-glucan, it is a part of cell wall of certain fungi. Okay. Now, the correct answer to this is mucormycosis. I know this is not a mainline testing that is done right now, but it's a very good test to rule out mucormycosis, okay, especially in the COVID patients. So technically, this test can be done for Candida, Aspergillus, and Pneumocystis jirovecii. You can remember the mnemonic CAP, okay, for this testing. So if you get a negative test for this, you can be sure that this is not mucormycosis, all right? Next question. A 24-year-old woman presents to the emergency department with complaints of blurry vision, headaches that started yesterday. She reports that she has been experiencing some facial pain, but she thought it was related to her dental braces. She's also worried about a black spot that is increasing in size on her face over the last 3 days. Recently, she had recovered from the COVID after using methylprednisolone for a while. The patient was diagnosed with the DM type 1 at the age of 15. The physical examination shows a black necrotic eschar. What is the most likely cause of this patient symptom? See, by now you have to start picking up this, words, catchy words here. Vision related problem, facial related problem, black colored spots, diabetes mellitus, use of steroids, all these things come under the characteristics of mucormycosis. So technically this answer is mucormycosis. You all know even anthrax produces a black colored eschar, but this history won't be there in that. All right. Next, the fungus or the mold that is grown on the onion is related to which disease in the humans? Okay. Now, the mucormycosis causes rhinocerebral disease. In fact, most of the doctors will pick this answer, okay, just by looking at the black color, black fungus. The media popularized the word called as black fungus. Technically, it's not the black fungus, dear friends. Okay, black fungus is the one that belongs to another group in fungi called as Demataceae group, or this one to be precise is Aspergillus niger. As the name says, niger means black, right? So this is not mucormycosis, which is also found on, decaying matter, etc. This is actually Aspergillus niger. And once I tell it's Aspergillus niger, I'm sure you will change your answer to otomycosis, right? So the correct answer for this is otomycosis. Next, guys, just a quick run through on this. Mucormycosis, please remember the important members here are rhizopus, the most common. In fact, the one is called as Rhizopus oryzae, Apophysomyces, okay, elegans, Apsidia, Mucor. These are all the important members here. Please remember that the molds are filamentous fungi, which are very delicate. Okay, so generally when you find them in the environment, they exist as spores, which are resistant forms. In fact, how do you get infected? By inhalation of spores, ingestion of spores, etc., or by contact to your skin. All right, where are they found? In the soil, decaying matter, etc. In fact, one more place, where there was this article, they said it's found in the cow dung as well. All right. Now, next thing, risk factors. You see all the risk factors right here. Please remember one important word. It's an angio-invasive infection. So because of this, it causes tissue necrosis, which eventually causes that black color. Okay. So important hints that can be given in your question is diabetes, use of steroids, iron chelators, burns, etc. Okay. Next, the diagnosis. How do you do the diagnosis for the mucor? Okay, you take a nasal swab. Once you take a sample from the patient, you're going to do something called as direct microscopy. So first you have to prepare a slide by adding 10% potassium hydroxide to that. If you're using that or another stain called as PAS or GMS or chalcofluor white, in all of them, you see a same appearance called as broad aseptate ribbon-like hyphae. Ribbon-like hyphae. So please remember this picture is very important for your exams. Now you are seeing two images. Now this guy on the left, guys, if you see they are comparatively slender and you see septae there. If you see septate hyphae with 45-degree branching, it is Aspergillus. So the picture on the left is Aspergillus. The picture on the right, where you see a stout, hyphae, which are aseptate, no hyphae are seen. Obtuse angle word they can use, or right angle, 90 degree, 120 degree, that kind of angles if you see, okay, that is nothing but this guy called as mucormycosis. Just another stains. This is the GMS, Gomori methamine silver. Please remember G for green background when you see, it is the GMS stain. Left side is mucor, right side is Aspergillus. Same story, KOH mound if you see now, you should be able to identify. Right side is Aspergillus, left side is mucor. Okay, this is the chalcofluor white, okay, where the fungi may produce this fluorescence. Okay, that's what you are seeing here right now. Finally, guys, when you take that sample, do the direct microscopy, some of that sample is inoculated on SD, Sabrod's dextrose agar. Okay. And how is this guy going to look like on gross examination? Cotton like growth. Okay. Whitish or grayish cotton like growth is seen for this. Whereas Rhizopus has a characteristic black and white growth that gives it something called as salt and pepper appearance. Now, I did the SDA culture. I will take some sample from there, and again I will do the microscopy, and the stain used is LPCB, lactophenol cotton blue. This time you're not only going to see the hyphae, but even the asexual spores called as sporangiospores would be seen. All right, please look at the picture. The one on the left, it's giving you that, cotton-like appearance, salt and pepper. Now you see two tubes here. The one on the left, which is more blackish, that's Rhizopus. Okay, the other ones are also mucors, but they're not Rhizopus. All right. The picture on the right, I'll just come back in 1 minute. The reason, why are we doing this microscopy in so much detail? Because in mucormycosis, there are many organisms. We just mentioned 3 to 4. There are many more. So we want to know, are these mucormycosis the ones which are common? And which are the common? Rhizopus, Absidia, mucor. Okay, so how do you identify them? Please look here. Okay, now first of all, dear friends, this point that you see here, it's called as a nodal point, okay? And then the structures below this, like roots, what you see are called as rhizoids. Rhizoids are present just below the nodal point in Rhizopus. And then these structures called as sporangiophore, which is looking like the bark of a tree, and the sporangium arises above that. The sporangium contains the spores of this organisms called as sporangiospores. These are the asexual. The sexual spores of this are called as zygospores. They cannot be seen on this. Okay. Absidia, what is the difference? This is described as internodal, this rhizoids, and mucor doesn't have that. Now, if you look at that picture exactly, you will see the rhizoids here. Okay. You will see the rhizoids, sporangiophore and sporangiospores. So that's it from me, guys. Wish you all the best. Over to Dr. Saurabh, and he's going to continue with the pharmacology part. Thank you very much.
Hello students, myself Dr. Saurabh Bhatia, and I will be taking about important topics of pharmacology for you. So let's talk about question number 1. All of the following drugs, which are the anti-COVID drugs, are RNA polymerase inhibitors except. So answer to this question is baricitinib. So guys, you can look in this question that any medicine that is ending up with this word vir, that is VIR, virus. So these medicines are antiviral. But baricitinib is a medicine that is not an antiviral drug. Rather, baricitinib is JAK inhibitor. That is full form is Janus kinase inhibitor. So baricitinib has an anti-inflammatory medicine that is approved for the treatment of severe COVID infection. And this medicine will take care of cytokine storm as well as the hyperinflammatory reactions which is taking place in severe COVID disease. So if we talk about the other medicines like favipiravir, molnupiravir, remdesivir, all these medicines are antiviral drugs. And as Dr. Salman has already mentioned that COVID virus is an RNA virus, it's a single-stranded RNA virus. So these medicines are inhibitor of RNA polymerase enzyme. So RNA polymerase is the most important enzyme for the virus replication. And if we inhibit this RNA polymerase enzyme, that virus cannot multiply and therefore the infection can be controlled. Therefore, these medicines are advised to be started in initial phase of this viral infection. So it is always advisable to give medicine as soon as possible. Like if we talk about favipiravir and molnupiravir, these medicines are advisable to be started in first 5 days of the infection when the patient has started having the symptoms. Remdesivir should be started within the first 10 days of the infection because after 10 days, virus multiplication is not that much, inflammatory reactions will start. So in late phase of this virus infection, there is a role of anti-inflammatory like steroids and baricitinib. But for initial phases, there is a role of antiviral drugs. Now, there is one medicine which is not ending up with this word vir, but still has an antiviral property. And this medicine is very important for your this year exam. And that medicine name is 2-deoxyglucose. And people must be knowing why this drug is important because it is discovered by Indian government, DRDO Indian government. So this is important for this year exams. So this medicine is not a main antiviral drug, but this medicine is always given as an adjunctive drug. So you have to give one antiviral, and along with this antiviral, you have to give this medicine, which is known as 2-deoxyglucose. Now, how this medicine will exactly act? Whenever you consume this medicine by oral route. So please remember, this medicine is available in the form of sachet powder. So we have to dissolve it in water, consume it by oral route. Now, once you consume this medicine, now this medicine preferably concentrate in the virus cell. And after concentrating in a virus will start taking up this medicine and start utilizing this glucose for energy. But the problem is in this medicine, the glucose structure is modified. And because of this modification of the structure, this glycolysis step get arrested, and therefore virus cannot generate energy for itself. And therefore virus growth will be arrested. So this medicine has an antiviral property, but medicine name is not ending up with this word vir. So please remember, this is the one drug against COVID, which is not ending up with vir, but still having this antiviral property. One of the important side effect of this medicine is QTc prolongation. So medicine can cause cardiac conduction problem, QT prolongation, and therefore, whenever we treat this treatment of COVID-19, there is role of some other medicines like azithromycin, hydroxychloroquine. So be careful, because these other medicines like macrolides and chloroquine can also result in QT prolongation. So this combination should be avoided. So one thing I would like to add on here, there is one drug we have discussed over here is favipiravir. So favipiravir is very commonly used in second wave of COVID. Now please remember, this medicine can result in theophylline toxicity. Now theophylline is one of the bronchodilator which is very commonly prescribed in COVID infection because of the bronchospasm associated with that infection. So please be careful. Favipiravir should not be combined with theophylline. And one of the important side effect of favipiravir is hyperuricemia. So many cases are coming up which are having this hyperuricemia, increased level of uric acid, as well as neuropsychiatric symptoms. Now, one more question. Which of the following is not the criteria to be met for using remdesivir in moderate to severe COVID-19 patients? So we know that remdesivir should be started in first 10 days of therapy, and this medicine is not given for mild COVID patients. Medicine is approved for moderate to severe COVID-19 infection. Now, there are some criteria which need to be met whenever we start remdesivir. It's not like that remdesivir can be given to anyone. Now, what are these criteria? You should know these criteria because these are the practical things which they can ask in your upcoming examination, because these days they are putting more stress on these clinical questions. So please remember, whenever we have to start remdesivir, the criteria are: number one, the patient kidney and liver function should be normal. And how we assess this? Patient eGFR should be more than 30, and patient liver enzymes levels should be less than 5 times of their normal. Second, patient should not be a child. Patient age should be more than 12 years, should not be less than 12 years. Number three, patients should not be pregnant. So we must be knowing the special population. Whenever a new drug is discovered, then clinical trials are not done on special population like children, pregnant, and very old patients. So remdesivir is a new medicine which is recently approved for this virus, and therefore the clinical trials on children and pregnant females are not done. So patients should not be a child, patients should not be pregnant, and patient liver and kidney function should be normal. And the most important thing is patient should be hospitalized. So this medicine need not to be given to a patient who is there in the house. Right, so home-based treatment, remdesivir is not advisable. So patients should be admitted in hospital. Number two, patient should be on oxygen support. So the patient does not require oxygen, patient oxygen is not dipping, then remdesivir will not give them much benefit. Will rather side effects will be more than the benefits. So patients should be requiring oxygen therapy. So in this question, they have asked which criteria is not required. So answer is patient not on oxygen support. So any patient who is not on oxygen support, remdesivir should not be given to that kind of patients. Number three, which of the following drug is not useful for the treatment of mucormycosis? Like Dr. Salman has already mentioned, one of the complications of COVID-19 is mucormycosis, mostly in those patients who are diabetic as well as immunocompromised. Now, which of the following drug is not useful for this mucormycosis? So out of these four, the answer is itraconazole. So please remember, there are three medicines. Number one, drug of choice is amphotericin B. I'm repeating, drug of choice, amphotericin B, especially the liposomal amphotericin B, which has minimal side effects. Number two, posaconazole we can give. Third is isavuconazole. Right? So isavuconazole, posaconazole, amphotericin B are three medicines which are given for the treatment of mucormycosis. You can remember these medicines with the mnemonic like PIA, right? Or you can make any mnemonic, whatever you want. But itraconazole is a drug is not useful for the treatment of mucormycosis. Now some special points about these drugs we discussed already. Drug of choice is amphotericin B. They can ask you what is the starting dose of amphotericin B for the treatment of mucormycosis. So the dose is 5 milligram per kg per day. And in some cases, when the condition is very severe, disease is very severe, we can increase the dose up till 10 milligram per kg per day. Now, how this amphotericin B acts against this fungus? This medicine will form pores in cell membrane of this fungus, and when the pores are formed, the macro and the micronutrients will start leaking out of that fungus cell, and that's why the fungal cell cannot survive, and this will lead to death of this fungus. Other important MCQs regarding isavuconazole. Isavuconazole is the only antifungal which is used in the form of prodrug. So after getting metabolized in liver, this medicine is converted to its active form. One more MCQ, this is the longest acting azole available in the market. So please remember, isavuconazole half-life is very long. It is more than 100 hours. Number two, this is the only antifungal which is given in prodrug form. Regarding posaconazole, please remember, whenever we give posaconazole along with fatty meal, absorption is better. Second MCQ, this medicine is mainly eliminated by a fecal route. This drug is not metabolized by liver, not mainly dependent on kidney. So liver and kidney are not the major organs which are involved in metabolism or elimination of this drug. Rather, this drug is eliminated as such via the fecal route through intestine. So please remember, drug is eliminated mainly by fecal route. Second, drug absorption is better when given with fatty meal. An important side effect of posaconazole and isavuconazole is QT prolongation. Again, I'm repeating QT prolongation because most of the drugs which we are using against COVID-19, they can lead to this QT prolongation. So you have to be careful about this. Next question. All can be seen as manifestation of amphotericin B induced nephrotoxicity except. So this question is based on amphotericin B side effects. So these days, we people are using higher dose of amphotericin B in patients with mucormycosis. So practically, we are facing these toxicity issues in day-to-day emergency clinics. Now, which manifestation is not seen with amphotericin B toxicity? So 4 options: hypokalemia, metabolic alkalosis, oliguria, and polyuria. So answer is metabolic alkalosis. So please remember, metabolic alkalosis is not seen in case of amphotericin B toxicity. Rather, it is metabolic acidosis, right? So what are the various manifestations of this amphotericin B on kidney? We'll discuss in short. Number 1, whenever we give amphotericin B, we have discussed already, this medicine acts by forming pores in the membrane of pores in the membrane of fungus. Now, in a similar manner, whenever we give higher dose of amphotericin B, this medicine can form pores in the cells of kidney tubules. And when this medicine will form pores in the membrane of tubular cells, those cells will get irreversible injury. Those cells will be those cells will initiate their apoptotic process, and that will lead to tubular injury. And because of this tubular injury, kidney tendency to retain ions like potassium and the magnesium ion will be lost, and this will lead to loss of potassium and magnesium in urine. So side effects are hypokalemia, hypomagnesemia, because medicine can cause acute tubular necrosis because of the damage to that membrane of cells of tubule. Now we have different forms of amphotericin B available in market. Like one is liposomal amphotericin B, one is amphotericin B deoxycholate. Now, like we know that in India, there is a scarcity of this liposomal amphotericin B in this COVID wave. So many doctors or many hospitals have used this deoxycholate form of amphotericin B. Now, please remember, deoxycholate has a detergent property, which has a more tendency to form pores in the membrane of cells. And therefore, acute tubular necrosis is more commonly seen with preparations of amphotericin B, which are other than liposomal form. Right. So liposomal amphotericin B is the safest of all, having the minimum chance of nephrotoxicity, but deoxycholate form has the maximum incidence of this nephrotoxicity. Number 2, this medicine can result in loss of water, because kidney will lose its tendency to retain water as well as ions. And when this water will start losing, water is started going out of this kidney will activate maculodenser cells, and that will activate the tubuloglomerular feedback that will cause renal efferent vasoconstriction. Because of this renal efferent vasoconstriction, the blood flow towards this kidney glomerulus will be reduced, and that will lead to oliguria. So one other manifestation of amphotericin B toxicity is oliguria. First is tubular necrosis. Second is oliguria. This oliguria is because of the activation of macula densa or this tubuloglomerular feedback. Number 3, amphotericin B can also result in resistance of the ADH action. So we know that ADH will act on collecting tubules of kidney, and that will lead to retention of water. So amphotericin B interfere with the action of ADH, and that will also lead to polyuria sometimes. So patient can come to you with polyuria. Now the fourth thing is, we have discussed already, amphotericin B can result in loss of magnesium as well as potassium ion. Now when this potassium and magnesium ions are started going out of the body, positive charge started going out of the body, as a compensatory mechanism, body will start retaining other positive charge, and that positive charge is hydrogen ion. And because of the retention of this hydrogen, patient will have tendency to develop metabolic acidosis. So various manifestations are decreased GFR, that is oliguria. Sometimes there is a polyuria because of ADH resistance. Number 3, patient can also come to you with metabolic acidosis. And number 4, electrolyte abnormalities are mainly hypokalemia as well as hypomagnesemia. That is all about important questions of pharmacology, which are based on COVID-19 treatment as well as drugs. Now I will request Dr. Anuradha to take this ophthalmology important aspects related to this COVID infection.
Thank you, Dr. Saurabh. And now we will be discussing few questions in ophthalmology. I'm Dr. Anuradha, friends, and I'll be sharing with you some expected ophthalmology questions as far as our INI, CET, FMG, and NEET PG exam is concerned. Okay, so let's jump ahead to the first question. Let's read through the statement. A 23-year-old lady develops mild redness in her left eye. She has no other ocular and systemic symptoms. Her father has been recently admitted with fever, cough, and breathlessness, and has tested positive for the SARS-CoV-2 virus. Which of the following could be the most likely cause of red eye in her case? What are the choices given? A, keratitis, B, optic neuritis, C, conjunctivitis, D, anterior uveitis. So now in this case scenario, friends, if you see, it's a young lady presenting only with red eye, okay, with a positive COVID contact. Okay. Now, among the choices, if you see, what are the choices which can cause red eye? From here, we can rule out optic neuritis because it does not lead to red eye. So we are left with A, C, and D. Now, among these choices, A and D, that is keratitis and anterior uveitis, will also have some other associated features. And what are these features? These features are there can be pain, there can be photophobia, there can be decreased vision, and so on. Okay, so what is the right answer to this question here? A lady who is positive contact with the COVID with only red eye most likely causes your choice C, that is conjunctivitis. So the question can be based upon these scenarios. Some more important points regarding the conjunctivitis in COVID. The most common manifestation in the eye of the COVID involvement is conjunctivitis. Okay, so this can be presenting symptom of COVID-19. The patient can present with a pink or red eye without any other symptoms. And what is the type of the conjunctivitis which we can see over here? That is the follicular conjunctivitis. So be prepared, the question can be there something related to conjunctivitis in COVID. Moving on to the next question. All of the following are true about the eye involvement in SARS-CoV-2 virus, except. Now, in these questions, which are all then none except, be very, very careful and don't jump to the first choice, which appears to correct. Okay, so we have to see what all are true except. Choices are conjunctivitis may be the presenting symptom of infection. B, there is high risk of transmission through ocular surface. C, may lead to retinal vascular occlusions. D, patient may develop double vision or painful eye movement. Let's go through the statements one by one and mark out whether they are true or false. Choice A, conjunctivitis may be the presenting symptom. We have just now learned that it is the most common presenting symptom. So choice A is the true answer. B, there is high risk of transmission through ocular surface. So please remember, the virus is found in the tears on the ocular surface, but still there is no proof that there is a high transmission from the tears or the ocular secretions with the infection. So this is not a proven statement that there is a high risk of transmission. Coming to C, may lead to retinal vascular occlusions. Very true. The cases of central retinal artery occlusion, cases of central retinal vein occlusion, etc. have been seen in the patients of COVID-19. Choice D, patient may develop double vision. Yes, due to the cranial nerve involvement. or painful eye movements, for example, in optic neuritis. So D is also true. So what is the right statement which is false over here? The right answer, which is the false statement over here, is your choice B, that there is high risk of transmission through ocular surface. This is not proven. So we will mark choice B as the right answer to this question. Now, something about eye involvement in COVID-19. As you can see on this slide, there is a long list of the conditions which have been found in the eye in patients who had COVID-19 infection. Okay, so every part of the eye almost and every layer can be involved either in the inflammation mostly or in the active infection. Okay, so most common what we have to remember is conjunctivitis, though it can present in the form of keratoconjunctivitis also, in the form of episcleritis also. Then vascular occlusions have been seen very commonly. Please remember central retinal vein occlusion, central retinal artery occlusion. There can be inflammation in the form of uveitis, which can be intermediate as well as posterior uveitis. Retina can be affected in the form of acute retinal necrosis, and there is a typical condition seen here, which is rather uncommon, what is known as acute macular neuroretinopathy, in which there is inflammation is only in the macular area. Okay? It can involve optic nerve in the form of optic neuritis. It can involve pupil in the form of AD stonic pupil. Cranial nerve palsies, they have been seen. Most commonly involved nerve is your sixth nerve, and patient can present with diplopia due to the sixth nerve palsy. Another point to be remembered, in certain patients, the Miller-Fisher syndrome has been seen. What is this Miller-Fisher syndrome? It is a type of Guillain-Barré syndrome in which there is also cranial nerve palsies like sixth nerve or third nerve. Okay, so this has also been seen, and then it can present as orbital cellulitis. So any of this presentation can be possible if there is a case scenario which is showing you that these presentations are there in the setting of COVID-19. So these possibilities, they can occur. Okay. Now I will take you to another clinical case scenario. A 60-year-old diabetic male patient was admitted with a 3-day history of severe breathlessness, pyrexia, tachypnea, and generalized malaise. RT-PCR from a nasopharyngeal swab was positive for SARS-CoV-2 virus. He was started on intravenous meropenem, oral oseltamivir, and intravenous methylprednisolone. On day 10, patient developed bilateral orbital swelling with right eye proptosis. Patient also had soft tissue necrosis of upper and lower eyelid. Left eye was immobile, and patient had dilated non-reactive pupil. What could be the most common organism involved? So don't get scared with such a long case statement. What is over here? The first part of the question, the key message from the first part of the question is that a diabetic patient was found to be COVID-2 positive. He was started on the treatment. However, the treatment also included intravenous methylprednisolone. So this is the key point over here. The second paragraph is telling you the changes which were found in the eye. So what are the changes? The patient has developed bilateral swelling of the orbit with right eye proptosis. Another key point is soft tissue necrosis of the upper and lower eyelid. Left eye immobile means all the extraocular muscles, they have become paralyzed. And dilated non-reactive pupil means that the second nerve is also involved. So this picture of orbital cellulitis-like picture with soft tissue necrosis in the setting of COVID-19 diabetic patient on intravenous methylprednisolone is highly suggestive of one very important infection which has been discussed by Dr. Salman and Dr. Saurabh. So what could be the most common organism involved here? Let's go through the choices. Aspergillus, Pseudomonas, Mucor, Candida. So I think now we can be very sure what we are discussing over here is orbital mucormycosis. So this setting, what can be the key features? So let me show you certain images also so that you remember all the signs well. So in the setting of COVID, along with immunosuppression, poor sugar control level, if there is a case in which the patient has developed orbital swelling, along with conjunctival chemosis, as you can see in the picture over here in the left eye of the patient, non-reactive pupil, double vision, pain in the eye, loss of vision, and very, very importantly, this black necrotic tissue, which has been highlighted, that this black color is not due to the color of the fungus. This is due to the color of this necrotic tissue, which is known as eschar. Then this is the setting of orbital mucormycosis, and we can easily answer these kind of questions. Okay, so few more important points about orbital mucormycosis, the points to be remembered about regarding the exam. The infection usually comes from the ethmoid sinus. Intracerebral spread, that is spread to the cerebral cavity, can occur when it passes through the orbit. Progression very rapid, and once it is in the orbit, the chances of cerebral spread and mortality is very, very high. The drug of choice, as discussed, is lipid-based amphotericin B. If orbit is involved, you have to do surgical debridement in the form of orbital exentration. Okay? So these were 3 important case scenarios in ophthalmology, which can present in the form of questions related to COVID-19 in your exam. Now I hand over to Dr. Rajiv to discuss about the ENT questions.
Hello friends, this is Dr. Dhawan. So I'm here to discuss a couple of expected questions for ENT in context to COVID-19 and mucor, of course. And these questions are expected for the NEET PG, for INICT, and for the FMG exam as well. Very appropriate scenario they can create like that. A 23-year-old female medical student has travel history by air 5 days back, and now she has developed fever since yesterday. Since this morning, she's complaining of loss of sense of smell, means anosmia. What is the most probable further investigation? So in the context of the clinical story they have made, there is a history of air travel following fever after the incubation period, like 5 days. And they are suggesting that there is anosmia, which is a very typical clinical scenario of COVID-19. So of course, what would be really required, as Salman very nicely pointed out, that the gold standard investigation to rule out COVID-19 would be, of course, RT-PCR. So that is the answer of this question, RT-PCR for COVID-19. And you must remember that anosmia, the loss of sense of smell, is a very important part of the clinical spectrum related to COVID-19 diseases. Okay. Now, another scenario they can make like this, like a 62-year-old diabetic patient and this post-COVID-19 patient, and now patient is presenting with blood-stained nasal discharge, and there is cheek pain also. The nasal endoscopy, which is generally the first investigation in a suspected case of any mucormycosis. In this case, the nasal endoscopy has revealed fungal debris in the middle meatus. You know that there is a typical look of the fungal debris in the nasal endoscopy we see, particularly in the middle meatus area. Some people call it peanut butter appearance of mucin also. The mucin is so thick and it is like amber colored, and that fungal debris is so typical, I would say, on nasal endoscopy, that you are quite sure, not conclusive, but sure about that we must rule out the mucor or a non-mucor fungal sinusitis possibility. So what is the best radiological investigation for this patient? So after nasal endoscopy has yielded a positive evidence of possibility of fungal sinusitis, of course, keeping fungal possibility and then mucor out of the all fungi, in this case, because there is blood-stained nasal discharge and cheek pain, and cheek is the house of the maxillary sinus. So shall we go for a CT scan, a plain CT or a contrast CT or a plain X-ray, or the contrast MRI of the peroneal sinus with orbit? The answer of this question is contrast enhanced MRI of the paranasal sinuses with the orbit. So this is an expected question for INICT, NEET PG, that what is the best investigation as far as radiology is concerned for suspected cases of mucormycosis. We must do the contrast MRI of the sinuses orbit, and we definitely include some cuts of the brain as well in this, because that mucor can spread to the orbit and brain both. And one more possible question again for NEET PG, INICT, or even FMG for that matter, for radiology particularly, that on the contrast enhanced MRI of the sinuses and orbit, you see a typical sign, and that is called black turbinate sign on contrast MRI. If you see this patient, like, this is the normal maxillary sinus, which is showing the black color. And this is the normal inferior turbinate, which is whitish in color, which is taking the enhancement. But on this side, if you see compare the maxillary sinus here, it is having, total opacification over here, and the inferior turbinate is actually blackish over here. So compare this normal side, which is a whitish inferior turbinate, and this blackish inferior turbinate. So this is now an expected multiple choice question for the radiology in the upcoming examination. So don't forget the black turbinate sign, which can be seen on the contrast MRI. Same over here. If you see, this is a normal turbinate, inferior turbinate. Now this is an axial cut, and this one is the black turbinate, which you can again compare. This side is the normal, and the red arrow pointing towards the disease side, and this is the black turbinate sign on the contrast MRI, which is seen in mucormycosis. Now, apart from MRI, just to add on to your knowledge, that we do get the CT scan also done in a case of fungal sinusitis. Every fungal sinusitis is not mucor. Aspergillus fumigatus is also a very dominant fungal entity which can cause fungal sinusitis apart from mucor. And if you do a CT scan, and then in the CT scan, you would be able to see a very typical finding, which is again an ENT radiology question. And this is heterogeneous or double density shadows on the CT scan of the sinuses actually. Now, when I say heterogeneous or double density shadow, you see over here, this is the orbit, and this is the maxillary sinus over here. And this is a big polypoidal mass, which is due to the fungal sinusitis formed. And this polypoidal mass is actually having heterogeneity. You can see this is more white than the surrounding peripheral area, which is more black. So guys, don't forget this clinical picture and this name, heterogeneous or double density nasal shadows or polypi on the CT scan of sinuses is suggestive of fungal sinusitis. I'm not saying mucor only, it is suggestive of fungal sinusitis, okay? Because normal polyp do not look like this. If you see, can you see the normal polyp over here? The first one is AC polyp, is the antroconal polyp, which is the inflammatory polyp, but a non-fungal entity. And you can see over here very clearly, this is actually homogeneous. This is absolutely a big polyp over here, but this is homogeneous polyp. But on this side, if you see, this one is again AFRS, means allergic fungal rhinosinusitis. So we are comparing a non-fungal polyp, which is homogeneous on CT scan, with a fungal polyp, which is heterogeneous on CT scan. And this is the variegated or double density or the heterogeneous opacity on the CT scan. Okay. Now, next question about the same kind of patient, 29-year-old RT-PCR COVID-19 positive individual, present with a necrotic debris in the nasal cavity with the necrosed skin of the external nose. Again, RT-PCR in the background. And now patient has got a necrotic debris in the nasal cavity with necrosed skin of the external nose, and KOH smear, as Dr. Salman pointed out, that it shows evidence of mucor, and Salman showed that beautiful description of how does the mucor look like and what is the best treatment of this patient. Now, this is a typical case of mucormycosis for sure, because KOH has already proved it, and clinical profile also supports that. So in the first look, you will mark amphotericin B as the treatment, but let me inform you, amphotericin B, the liposomal one, is not the only treatment. You have to do the surgical debridement also. So the answer is not A in this question, the answer is D. Please do not mark A, amphotericin B, along with debridement. The surgical debridement is the right kind of treatment plan for the patient of mucormycosis. Now, why debridement? It's a black fungus, black meaning necrotic. Why, the mucormycosis can be seen in a background of young diabetic patient, HIV positive patient, COVID-19 patient on steroids. That's a very possible clinical scenario. But why there is a blackish thing over here? Because this mucor is an angioinvasive fungus, and that angioinvasion leads to ischemic necrosis. And ischemic necrosis means the color of the tissue will turn black, and that necrotic dead tissue needs to be removed. That's why we do debridement first, and then we give the liposomal amphotericin B. Okay, that is the treatment plan of the mucormycosis patient, and that's all from my side. And I'll thank each one of my friends, Dr. Saurabh Bhatia, Dr. Anuradha Dhawan, Dr. Salman, for wonderful presentation. It was a very humble, I would say, attempt on our part to help our undergraduate students to really be aware about what are the possible clinical scenario-based questions in the domain of microbiology and pharmacology and ophthalmology and ENT. As we are very much well aware that integration is the trend right now. Integration, that's how this session was planned. And I thank you, Dr. Salman. I thank you, Dr. Saurabh, and I thank Dr. Anuradha also.